Well, everyone, good morning, good afternoon, good evening to our colleagues around the world. Thank you very much for joining us today for a very important and interesting discussion I think we have here for you today. My name is Kelly Ambrose, and I'm a senior analyst for the Health Finance and Governance Project at Abt Associates. This webinar is being hosted by the Malaria Economic Research Community of Practice, which was established about a year and a half ago and aims to improve the communication and collaboration among users of malaria economic research, producers of that research, and students of the research as well as malaria programs. COP is supported by USAID's President's Malaria Initiative, PMI, and facilitated by the HFG project. Currently we have over 150 members, spanning over 22 countries and more than 40 unique organizations. And I'd like to just emphasize that this is an open group to which anyone can register. In the chat box, or WebEx, you should see a link to the COP website. Please take a moment to register either now or at the end of the session so we can keep in touch with you and let you know about the latest events that the COP is holding and things that we're working on. A few housekeeping items before we begin the technical content of our session today. We're using WebEx as our webinar platform this morning, and we're hoping to have as engaging and interactive session as we can. We'll be recording this session and posting a link afterwards to the COP website. And joining via your computer, currently you should see a slide which describes two of the interactive features for WebEx, the key feature and chat. These buttons are in the top right corner of the WebEx window. And click on these buttons, they should bring up small panels on the right side of your screen. Please use the QA panel to ask any questions that you may have, either about the presentation or during the discussion portion of the meeting. Use the chat panel to interact with your fellow participants, or if you're experiencing technical difficulties. You see in the chat panel there's a send to box where you can select who to send a message to. If you have technical difficulties, the person that you need to select is Alina Sims. She's my colleague, and we'll be more than happy to help you try and troubleshoot those. The third interactive feature that we're using today is polling, and we'd like to use this to get a sense for who's joining us. So Alina, if you wouldn't mind starting the poll, those of you who have joined on your computer, please indicate via the poll what role or roles you play in the malaria economic research world. Note that you can select more than one option. We know that many of you play multiple hats in this sphere. So I think the poll is coming up. If you don't see it yet, be patient. Alina, would you mind starting the poll?
Sorry, we're having one small technical difficulty. Give me 1 second.
Okay, let's go back. Let's keep moving, and we'll come back to the poll and get a sense for the audience in a little bit if we can resolve our technical difficulties. So our agenda for today, we're going to begin with a short presentation and then follow that with a moderated discussion, which will include time for Q&A from the audience. We have a great panel of discussants from the community of practice joining us today, and I wanted to just take a quick moment to introduce them. Sophie Faye, Dr. Sophie Faye is my apt colleague who works on the HFG project as a health economist and costing and economic specialist. Dr. Elimination is joining us from Dakar. Dr. Gay is the Case Management Training and Research Officer within Senegal National Malaria Control Program. Welcome, Dr. Gay. We have Dr. Justice Mignon dialing in from Ghana, where he is a senior lecturer and health economist within the School of Public Health at the University of Ghana. We have Rima Shreta joining us from Singapore. He is the Associate Director of Economics and Financing at the UCSF Global Health Group's Malaria Elimination Initiative. Welcome up. And we have Duncan Earle, who's the Director for Country Programs of PATH's Malaria Control and Elimination Partnership in Africa, better known as MASEPA. Duncan is based in Zambia, but he's dialing in from Washington, D.C. today. I'm also joined by my colleague, Dr. Elaine Barua, a senior health economist on HFG, who will be moderating the discussion portion of our session. Combined on this panel, we have nearly, I think, 75 years of experience, so very impressive indeed, and we're looking forward to discussing. So without further ado, I'd like to hand over to my colleague, Sophie Faye, to get us started with her presentation. Sophie? You need to unmute. I'm not hearing you on my end.
Oh, sorry.
There we go.
Thank you. So thanks so much, Kelly, for this introduction. My name is Sophie Faye, and I'm a costing and economic specialist on the HFG project. This morning, I'm going to be talking about a study that the HFG project did in close collaboration with the National Malaria Control Program in Senegal, where we're looking at the cost and effectiveness analysis of strategically packaging malaria intervention. So presentation will go over why we did the study, we'll review the results, what did we find, and we'll talk about implication of these results in terms of planning and budgeting for malaria control and elimination in Senegal. So for this third piece, we are very fortunate to have Dr. Gay from the National Malaria Control Program, as Kelly mentioned, as part of this. So hopefully he'll be talking more about how the program will be using these results. So as we all know, no single intervention will achieve malaria elimination. Instead, a package of interventions should be used, and this based on malaria transmission intensity in a country. So this concept, which was first started by MASEPA, has been something that countries have tried to use. The current stage of the resources in terms of malaria elimination, resources being limited, and cost effectiveness data being a necessary tool for decision making, see a lack of cost effectiveness for these packages. These packages that countries have moved to use have very few studies looking at their cost effectiveness. So for this, we'll just try to fill part of that gap by looking at cost effectiveness of these packages in Senegal. The part objectives here were to estimate a cost effectiveness ratio for the different packages of malaria intervention in Senegal, particularly using routine data as opposed to modeling, and using those results to identify potential efficiency gains and lessons as malaria epidemiology evolves in Senegal. In these slides, you're going to see a map of incidence, malaria incidence in Senegal. As we go from north to south, malaria incidence increases. The green piece of the map is mostly district with low incidence of malaria, less than 5 cases per 1,000 population, while red districts are mostly high incidence with more than 25 cases per 1,000. So in terms of packages, these are the different packages being implemented, and you can see that they follow the incidence map in a way that they have this basic Sophie package, the first package, with scale up for impact. And Sophie has different intervention in it, science, IPTP, RTs, ACTs, so case management from facility, as well as PECADOM, which is a community-based case management. Sophie is the basic package, and it's nationwide implemented. On fee, depending on incidence, they add some other interventions. So the fifth package is fee plus RCI, reactive case investigation. This is mostly implemented on those green districts that we saw earlier in the north, where malaria incidence is low. And it's basically using focal screen and treat and mass screen and treat. We have also other type of intervention being mostly implemented on Sophie in the control areas, and are either SMC alone, IRS alone, or a combination of SMC and IRS. So these 5 packages in Senegal, they're what we studied in terms of cost effectiveness. Analysis is a retrospective one for the 2013-2014 years. And these 2 years were the first one where packages was occurring. That's why we chose them. So we right here want knowledge that the short time period is a limitation to our study, but as I said, this was the first year, and we want to think of this study as a baseline study for when all of these packages were going on, and later on other studies can build on this and see what evolution we have. Big level data we were able to get for all 76 districts in Senegal in terms of incidence of malaria, mortality due to malaria, intervention coverage, the out of the intervention, and the cost. Analysis of cost is only taking into account the direct financial implementation cost. We account for economic costs, neither did we account for costs related to patient. So we calculated the cost, total annual cost of interventions using soft top-down and bottom-up approaches. And those costs of intervention was aggregated to get the cost of a package. For effectiveness, we used DALI averted because DALI averted was able to give us a common measure on our preventive and treatment intervention that we have. And then cost effectiveness ratio is just a ratio of the cumulative cost of packages in areas where they are implemented over the cumulative effectiveness in terms of DALIs averted. Some results, selected results that we wanted to share with you today. So we start with the total annual cost of packages. In this graph, you will see that the x-axis represents the amount in terms of total cost of packages, broken down by the total cost of the intervention inside those packages. And then the y-axis, you have the different packages and the number of districts where these packages are implemented. One thing to note here is Sophie, which is in more districts, 54, has the highest total cost. Now, importantly, Sophie only, in terms of total cost, we are dominant of LLIN. So the blue piece of the bar is the LLIN part of the cost. We want to note the situation with the total cost of packages where we have IRS. So in those, which are the second bar from top and second bar from left, the purple part of it, which is IRS, we can see dominate. We see a domination or quite same level when we look at the middle bar, which represents the Sophie plus SMC. Here, the SMC piece of it, the green part, is almost the same as everything Sophie. And remember, Sophie has 4 different interventions in that package. So the Sophie plus RCI package, which is the first bar from top, the red piece of it is representing RCI. So looking at unit cost, we can see better the real cost when it comes to beneficiaries of these interventions. Something to note here is that prevention interventions in general are cheaper, so are having a lower unit cost than treatment. And among those prevention, IRS has the highest one, $357 per beneficiary, while in the treatment group, RCI is having the highest cost with almost $10 per case investigator in those places where malaria incidence is low. Then coverage also see from there that WAS and SMC have very high levels of coverage, and IPTP, they have fairly relatively lower level of coverage. So remember that LLINs and IPTP are part of the Sophie package, the basic one, which is just nationwide. So with this level of coverage, it appears that potential efficiency gain would still be possible if we were to increase this coverage. We can still see that unit cost per capita shows a relation of the package where we have IRS. The Sophie only package here is the one that have the lowest unit per capita, around $0.50. First, we want to see what happened with effectiveness. All study period, we saw a decrease in both incidence and mortality for packages, all of them. So the decrease, though, in incidence is higher with packages that have SMC. So the Sophie plus SMC and Sophie plus SMC RS, so a higher decrease in incidence. When it comes to mortality, the packages with IRS this time have highest decrease in mortality. Effectiveness ratios show very wide range in terms of this cost per DALY averted. It goes from 81 per DALY averted to almost 1,300. But importantly, WHO guidelines related to GDP per capita, we see that all of these packages are either cost-effective or very cost-effective. Important finding, but we go to comparing relatively these packages, we see that Sophie plus SMC with $1 per DALY averted is the most cost-effective one. The Sophie plus RCI, reactive case investigation, with 1,300 is the least cost-effective. These selected results just key takeaway that we want to share with you today, and the first being the intervention in packages based on incidence, as Senegal is doing it, could be recommended to other countries. And it could be recommended because the study found that this is cost effective. So say we start earlier in the guidelines, all of the packages are cost effective. However, we're careful in comparing in terms of relative package cost effectiveness because we have here a mix of control and elimination packages. We do that just from the nature of these two phases of control and elimination, the cost effectiveness will be different. With control, we have a lot of cases, so we'll have bigger effectiveness. But when it comes to elimination and less cases of malaria are present, it's going to be harder to get to that last cases. So the effectiveness of those packages might be less than what we have for control, but it doesn't not mean that elimination should not be pursued. It's just going to help kind of know how to plan and how to think of their strategy when they're into elimination. A takeaway here is we saw Sophie plus MC plus RS that was most cost effective than just Sophie plus RS. So it looks like when you add SMC and RS together, you get more in terms of cost effectiveness than just RS. And then the efficiency gain possible with increase of these two key preventive intern is also something we want to note. LLIs and IPTP are a relatively lower coverage in Senegal, and we feel like if that could be increased, that coverage, it can help boost the effectiveness of this package. We want to note that this type of study wouldn't be possible if we didn't have very detailed data on malaria surveillance. We were able to have that in Senegal, and we think this type of strong surveillance and outcome monitoring system we needed if countries want to go in this type of very specific studies. So these are some of the things we wanted to share, and we'll be very happy to see your opinion on when we move to the discussion. But I wanted to really acknowledge the National Malaria Control Program in Senegal and the Ministry of Health, who were very cooperative while doing the study and opened all of the data they have for us. Also, all of the implementing partners in Senegal working on malaria share their data with us, and we want to thank them. We thank our local research coordinator as well as all of the team in Senegal who made this possible. So this ends the presentation, and I'm happy to get any questions or comments about the work that we done. Thank you. And now hand to my colleague Elaine Orwa, who will now the discussion.
Can you hear me? Sorry, I think the internet's a tad slow, so it took a little bit to unmute. Okay. Thank you for the presentation, Sophie. And I'd just like to also say thank you to the panelists for joining us today. Also for taking the time to provide comments on this piece of work. It will be published shortly, so all your comments are extremely appreciated. Before we go to a general discussion, I'd like to give our panelists an opportunity to ask Sophie any questions that they may have around the approach and methods that were used, and possibly any questions around the results. So I think our panelists should have been unmuted at this point and are free to ask Sophie some questions. After that, we'll also take the questions that have been popping up in the Q&A function, and I'd encourage folks to use the Q&A functions to submit their questions. I see that we have 2 already, so I know it's working and I know how to use it. So I do encourage you to put some questions there as well. But first, to the panel, any questions or comments for Sophie?
Let me thank Sophie for that great job. But a quick question. I wanted to find out, I saw on the slides you presented that these packages took place in different districts in terms of number of districts. So I saw a couple of them taking place in 2, some in 4, other, you said Sophie in 54 districts. Does the non-uniform number of districts have an implication in terms of the number of effects, and cost? Certainly they would have. I'm just wondering how you tackle that. Having different districts certainly would have a different number of effects. So how you standardize that to ensure that we're making the packages comparable?
Thank you, Justice, for that question. And it's right. These packages are not uniformly implemented, so some of them have lower district implementation than others. And I should point out that that is just the reality of things in Senegal. And one of the things that we really wanted to do is paint that reality, what's happening and how it's happening, what it's costing right now with that level of implementation. So it's true that in terms of cost, we cannot quite compare and say the package Sophie, for example, that have 54 districts compared to package Sophie's IRS only implemented in 2 districts. Not to relatively compare them, but I think what it tells you is that you have 54 and a certain package. A portion of cost, what you from 2 districts and a certain package would let you know if you want to expand the Sophie plus IRS, think of the cost that you're going to incur, because only in 2 districts you have almost half of the cost of whatever is implemented on 54 districts. We didn't try to standardize the number of districts because we wanted the National Malaria Program to know what it was costing with where they were implementing this.
Thank you. Are there any other questions or any follow-up questions? Okay.
Thank you for the presentation. I'd like a definition. On one slide, you have unit cost per beneficiary, and on the next slide, you have unit cost per cut. And I'd like to have you tell me how you define that. I also clarify that in 1314, there was only active case investigation actually going on in 1 district, in Richard. There was some research work around mass test and treat going on in some other districts, but it was not the active case investigation.
Yes, so for first question, beneficiaries, we mean they're the people who were affected by the invention. So for example, when we say IRS, beneficiaries was the people who were protected by IRS. So everybody who, because the implementing partner spread a house, they consider that those people are protected. So that's the beneficiary, so the direct beneficiary of that intervention. For SMC, for example, it would be those kids.
For active case investigation, what's the definition of a beneficiary?
The number of cases that were investigated and the people who consequently got tested for malaria and made treated. Okay. Those were the beneficiaries for RCI.
Okay.
And for your point about the districts, yeah, in 2014, MSAT was happening in 3 districts in the north, and FSAT was happening in 1 district. That would be, I think, Richard Toll was FSAT, and then I'm blanking on the 3 for MSAT, but they were in the north as well, and we got actually data from your colleagues in Senegal that I want to thank as part of the implementing partners. any other question from the panel?
Hi, it's Rima speaking. I just have a question and a comment. The comment just going back to what you had already mentioned in terms of comparing apples with apples and not just using cost-effectiveness analysis, this kind of cost-effectiveness analysis to justify not going for elimination, given that elimination in your study, the intervention to be less cost-effective than control. So that we're really comparing the two issues equally. So I would just wanted to highlight that, as you already have, and also highlight the fact that for elimination, we really do need to consider those other external benefits, including regional benefits, including productivity losses, even the fact that we won't have malaria anymore, and how do you can't really build that into a cost-effectiveness analysis. So just a note of caution, particularly to listeners on this call that are thinking about doing economic analysis in an elimination setting. But I had a question with respect to the reactive case detection. What was that actually being, all of the interventions that you're comparing, are they being compared to do nothing or the previous interventions that were done? And why use cost effectiveness rather than incremental for RACD?
Thank you so much, Rima, for your comments. And again, we can't emphasize enough that the goal is really not to deter from elimination. This is going to be needed, and it's going to be different, and it's going to have different benefits. To your question of did we deal with that? Sorry, can you repeat the last question? I got trouble there hearing.
Asking whether the comparison is to do nothing approach or versus what the country was doing before. And we found that, at least in the studies that we've been working on, when we're comparing particularly with reactive case detection versus other forms of surveillance, and incremental cost-effective analysis works better. Yeah, thank you.
So we're not comparing with the situation of nothing being happening. We are just looking at the situation with everything going on those 2 years. They were already implemented, and telling them, the cost effectiveness of each one. And I guess here idea would be, as you say, compare what's comparable, so they can still compare the control packages and see relative to each other what is happening. And at least on the elimination package, they can see what is it that they should plan for if more districts should go into that elimination. So definitely more relative component than comparing from with a situation where nothing happened. And this is actually why we did not do incremental, because we don't have a situation before where something or nothing was happening, or something lower level was happening, and we see an increment. So we did not do incremental cost effectiveness ratio. We just did cost effectiveness ratio, as we wanted to focus more on helping the malaria control program see doing things, because we wanted to get and stay real with this study. So it's already happening. They're already implementing those packages. So they want to know what's going on with what they're doing and how to move forward. So that's really why we kept it to compare relatively instead of the incremental effectiveness ratio.
Thanks, Sophie. We have a couple of questions from the webinar audience, and I think a couple of them are quick, and then a couple of them may be not so quick. So we may not be able to take all of them, but I can run them by you, Sophie, and you could respond. Thank you, Bright Audrey, for your questions. Bright's first question was, how was project staff salary handled? Was it included? That's the question, right, Sophie?
Yeah. Yes, it was included. The staff that directly work on those projects, their salary was included. We just did not include anything that is upper management. So if an implementing partner's headquarter is in the U.S. and they oversee work in Senegal, that's not part of it. But whoever is in Senegal working on those malaria interventions, the salary is in there.
Got it. Second question there is, how was the community case management of malaria implemented? Was it community-based or was it outreach? Even though it would have been great to see cost component, and actually I think Sophie didn't present the cost components now, but I think you do have other presentations where they are shown. I was just wondering, because we actually have Duncan on the line, I wondered if Duncan wanted to address this question around community management.
I'm happy to the extent that I can. In Senegal, they have a system called ECODOM, which is community case management using a community caregiver. These are really deployed in areas that have poor coverage of health centers, and so they tend to be more rural. It is a community-based agent who tests and treats passively. They actually are involved in, but do not direct, the reactive case investigation work that's been going on in research.
Great. And Duncan, these community-based workers, they don't only address malaria, isn't that correct?
They principally address malaria. They refer for any AT-negative febrile illness.
Yeah.
Okay. Thank you. And then we have, oh my goodness, and they keep coming in. I think we're going to this one, the last one, so that I can get to the questions that we have for the panel. When you say control packages, do you mean prevention interventions that are preventative? So is that what you mean when you say control?
No. In here, control is the contrary of elimination. Basically, control is for places where malaria is still high in terms of incidence, and we're trying to control the epidemic. And doing all of this mass intervention, RS, SMC, coverage for nets, things like that. That's control, and we think of elimination as being those part of the country where they're able to get malaria to levels very low, less than 5 cases per 1,000, and now the effort is to actually eliminate it from there, which is why they're using the reactive case investigation. Basically, just whoever comes to the health center with malaria, they get treated, but then their family is tested and their neighbors are tested and treated just to prevent this malaria to spread.
Great. Thank you so much. So now I'd like to move to, and thank you to everyone who submitted questions. I'd like to direct some questions to the panel. So the purpose of the community of practice is to really explore malaria economic research in terms of what we have, what we don't have, what approaches are underutilized, what do we need to have more of, and so on. So this particular study, as Sophie has mentioned, really conducted to support planning and budgeting and with the malaria program in Senegal, which is experiencing this epidemiology that many other countries will also experience. In the north of the country are pre-elimination, and then we have endemic malaria in the south of the country. And we're using some economic methods to best understand how to program money, basically, how to program money and interventions in this sort of environment. So I'd like to ask both, I'd like to ask Justice, if that's okay. Obviously, Sophie's raised some issues around cost effectiveness and comparing combining elimination interventions with interventions where we're actually sort of treating cases as we are in southern Senegal. From a researching point of view, with the focus on malaria elimination, what should we be trying to understand, and how could we best guide ourselves, our country programs, with regards to where to put the next dollar, basically, that's going towards malaria, given that there are things we could be doing that are pre-elimination and things we can doing that are sort of with malaria cases as we're currently experiencing them. What are your thoughts moving forward?
Thank you, Elaine, and thank you, Sophie, again for that great effort. Well, in a developing country myself, I truly appreciate the realities of data, and when it comes to the field, how you really need to navigate around this. Having said that, I think the idea behind this study is a whole one. Is that I think needs expression. It is that we are all saying that we are going to elimination. Now, how do we ask, the economic worth of conventions together? So that is a key question to do. I think that put doubt in my mind that cost effectiveness in itself can help us answer that question to a large extent. Note that there are a few challenges within, what Sophie and the team had to face, and within cost effectiveness itself that may, have affected the way that some would view this cost effectiveness. But I have no doubt in my mind that cost effectiveness in itself is a tool to us and then how to move forward. Having said that, I think the real issue here, the challenge is the issue of data. You would expect that actual data, which is the routine data, better for making in-country decisions than modeling, and we made those decisions over and over again. Even the problems with routine data in Africa, and the quality of data, it makes one wonder whether in this case, and until we are able to improve the quality of routine data as it is now is the best in terms of compared with modeling. But I think that the clear thing is cost effectiveness is to help decision makers know where to put their money. Of course, there are issues, we've discussed issues about some of the solutions which we will come back to later on, but just to answer your question as it is. Countries would be better helping, using cost effectiveness data.
So then my next question would be for Rima, and I hope it's appropriate to direct this question to you. There are large push globally now, and that's why we're using the term malaria elimination, which I would say we probably weren't using so much 5 years ago. In a country like Senegal and other countries that qualify for, say, global donor support, what's the thinking around what to support, and what sort of information, if any, is needed to identify where best to sort of funnel the substantial amount of global sort of money that's around for malaria. What's the thinking like, and how can Malaria Economic Research help make those decisions for donors, particularly in an example like this in a country that's got both endemic regions, large endemic regions, but also large elimination regions as well, or pre-elimination regions?
Thank you for that question. As you might say, there are large global donors currently which kind of, after the global economic crisis, have had to kind of retrigger their support for communicable diseases, and donors, including the Global Fund and others, are actually prioritizing now high-burden countries, which tends to mean the total number of cases in the country, and low-income countries for financing, which in fact puts countries that are trying to eliminate at a bit of a disadvantage. The Global Fund, for example, does use two metrics, but it uses a country-wide allocation to decide on the level of financing that the country will get. This to be problematic in a country with heterogeneous malaria transmission, like Senegal, like the Philippines, and others, which have regions or pockets of high transmission, or sometimes even pockets of vulnerable and marginalized populations. So, for example, in Asia and in Southern Africa, you have so much population movement at the border areas, and populations are often marginalized, they're migrants, workers that don't have access to health services, but they bear the brunt of the burden. So we do need to continue to advocate for donors to continue to prioritize and not punish countries that have successfully driven their burdens down. But we also need to advocate to support them in successfully transitioning from donor financing, and at the same time recognizing that some populations, like those marginalized populations or the hotspots, will still need support. And I think that we can definitely use economics and economic studies for the evidence for advocacy. And malaria elimination, in that sense, needs to be viewed as a global public good, benefits more than just that immediate population at risk. It benefits the region, it benefits multiple levels, and sometimes it needs to continue both at the donor level and at the domestic level in the same way as countries continue to vaccinate children with the absence of disease. So we can certainly use the economic argument, particularly around the fact that, to me, the biggest investment into malaria elimination is the fact that we don't have the disease anymore. So apart from being a cost saving, a cost saving to the health system in the long run, it's a cost saving through increases in tourism, through better cognitive development, through losses, through having absenteeism for work and for school. So all of that needs to be considered in an economic argument and the evidence that's presented to policymakers and donors.
So that's something researchers, for example, may want to sort of focus on, how best use the available data that we have, given the limitations, as Justice pointed out. How to use the available data we have to sort of make that case, particularly for elimination, in a way that captures the broad benefits, not just benefits to the case that gets, for example, in Senegal, the reactive case intervention, not that case, but the fact that there's a combined benefit to having and expanding that area that is pre-elimination, expanding that so that we have less of the disease to conquer. Just to take us back then to Senegal specifically, I think we have, I know we had some technical difficulties. I think we have Dr. Gay on the line, and I wonder, Dr. Gay, if you could tell us how this data has been useful to you in Senegal for planning and for looking at your program and your program's performance. Dr. Gay?
Yeah, I'm here. I'm on the line. Yeah, that's
how
what
has
I
this
was
information
saying,
been useful?
Last year when we were... Are you hearing me?
Yeah, we can hear you.
It's okay?
Yes.
Yep.
I
think that's what I was... That's what I was saying last year in ASTMH when we were presenting the study with Sophie. That's why I think it's very useful for the program. Because, you know, that helps us to improve our decision making in a way to invest in pre-elimination. So I told it last year that we need this kind of studies because you know now we'll have more arguments for advocacy with our financial partners like PMI, like Global Fund. So this information will help us to make good decisions, to know where we have to invest and how fast we will need for prevention. It's my opinion.
Thank you, Gay. And actually, we didn't emphasize that, perhaps to this point. The fact that costs had to be collected allowed us to have a look at total costs as well as cost effectiveness, because the cost effectiveness is useful for making comparisons within interventions that are achieving the same objective. But it is actually the total cost are probably of the most use, is correct, Dr. Gay, because it's total cost that a country actually has to plan and budget for, not a cost effectiveness ratio. So just to continue the follow-up in Senegal, I think we have Duncan still aligned. This approach of the scaling up for impact, could you just tell or share with us why you went about, or why MASEFA and the National Control Program for Malaria in Senegal, why this was developed? Because I don't think this is actually commonly done in many countries. So what was it that provided the impetus for approaching sort of the designing malaria control in Senegal this way?
So, with all due respect, Senegal implemented Sophie in the second half of the 2000s, along with a lot of countries across Africa. They didn't necessarily call it that, but it was based on some work they had done in Zambia, suggesting this was, when we have great tools deployed. So, I think this is sort of the basic package. I'd really like to address is, I think as countries think out and state ambition to go to elimination, I think there's some value in comparing the cost effectiveness interventions that are designed to do the same thing, such as vector control. But I suggest that the important questions for countries to wrestle with that are going for elimination is thinking of the cost efficiency that they can achieve in deploying these interventions. And, I addressed some issues with Sophie on some of the data, but, the reactive case investigation, for instance, in Richard Toll district, evolved from testing and treating in every individual index household and the 5 neighboring households, in testing thousands of people to find tens of cases. And over time, that approach evolved to only testing in the index household and then screening neighbors for peak risk factors that were identified over the course of the first half of implementation. Those were recent fever, recent travel, and failure to sleep under a bed net the night before. And that still resulted in thousands of people getting tested and tens only being positive. It's actually now moved to a approach where simply treating the entire index case household and leaving it at that. But efficiency, and that's trying to move towards cost efficiency. I also suggest that we need to be careful about attributing all declines in incidence to mentions. We've done some early analysis in Senegal that makes it look like there was a downward trend over time anyway, and it's not clear to us whether the active case investigations or the local drug administration was necessarily leading to fewer cases. What it was doing is giving us information, for instance, that 70% of all cases identified in Richard Toll are actually from people who've traveled outside the district in the prior month. So I think, cost effectiveness is somewhat helpful, but if a country is committed to elimination, then what they really need to think about is how can they be more efficient? And that would go to our ingredient-based costing methodology to understand what the numbers of costs for a given intervention that might be able to be addressed with a more efficient approach. Thank you.
Right. I think those are very fair points to make, and they sort of argue for a closer engagement, I think, between programmers and malaria economists, because that's how we capture the nuances that you've just described and work out how we're going to use the data appropriately, or how we're going to capture the nuances that you've just described in programming, Duncan. So we are actually just 1 minute over time at the moment, and I'm sorry, I almost wish we had scheduled for a longer session. So given that we're 1 minute over time, I'll have to hold the question and answer at that point. But I think that anybody who has further questions, particularly around efficiency, as Duncan has raised, I would encourage you to be in contact with us, because Sophie presented some of the data, but there is actually quite a lot to learn about efficiency variation between how each of those packages was implemented, but it wasn't covered today. So it's great that you raised that point, Duncan. I think at this point, let me just quickly say thank you to Dr. Gay, to Rima, Justice, Duncan, and Sophie for their presentation, and I'll hand over to Kelly, who I think is going to close us out.
Thanks, Elaine. To continue the conversation, we invite you to not only register for the COP on our website, but also join us next week at ASTMH. You'll be involved tomorrow. On Tuesday, we have an opening, and you can drop by for any or all of the 4 sessions that are listed on the slide. And again, please be sure to register for the COP. I think Alina has put the link again in the chat feature, so that we can be in touch with you and you can let us know how you'd like to be involved. We will post a recording of this session as well as answers to all of the questions that we received. Thank you very much for joining us, and have a great rest of your day. Thank you.
Thanks. Thank you.
Thanks much, Justice and Duncan and Rima. Cheers.